On cardiopulmonary bypass, we cool patient to protect their organs, but cooling creates a physiological dilemma. As temperature falls, blood becomes more alkalotic, carbon dioxide behaves differently, and hemoglobin holds oxygen more tightly. The result, oxygen may be abundant in the blood, yet harder to unload the tissue. So, do we let physiology take its natural course, or do we intervene and force the blood back to normal? This is the story of alpha stat versus PS stat management. To understand alpha stat and PS stat, we first need to understand something surprising. Neutral pH is not always 7. Neutral simply means the concentration of hydrogen ions equals to the concentration of hydroxyl ions. At body temperature, water dissociates more readily. As a result, the pH of neutral water is approximately 6.8. Now cool the water, the temperature decreases, water dissociates less. The neutral point moves upward at 25 degrees Celsius. Neutral water has pH close to 7.4. Nothing has been added, nothing has been removed. The definition of neutrality has simply changed with temperature. And if neutrality change with temperature, what should we consider normal pH during hypothermia? The question lies at the heart of alpha stat versus pH stat debate. Alpha stat is based on a simple principle. Instead of trying to maintain a fixed pH, it maintains a normal relationship between hydrogen ions and hydroxyl ions. Human blood normally maintains hydrogen ion and hydroxyl ion ratio approximately 16 to 1. As temperature decreases, the neutrality point of water rises. Blood pH rises in parallel. At 37 degrees Celsius, blood pH is approximately 7.4, while the neutral water is about 6.8. At lower temperature, both values increase together. Blood continue to track neutrality. This preserves the electrical charges of protein and the function of critical enzymes. So alpha stat accept the natural rise in pH during cooling. It allows physiology to follow its natural or normal temperature dependent pathway. Let's see what happens in a real patient. Different regions of the body exist at different temperature. Cold peripheral tissue may be significantly colder than the core. As tissue temperature falls, carbon dioxide becomes more soluble. More carbon dioxide dissolves in the blood. The mean partial pressure of carbon dioxide decreases. At the same time, blood pH rises. Cold blood therefore appear alkalotic. Meanwhile, warmer tissue continue to producing carbon dioxide and remain relatively acidic. The important observation is that the blood pH continues to follow the changing neutrality point at the each temperature. The body naturally behave according to the alpha stat principle. Now, let's compare the two strategies. Alpha stat uses blood gas values measured at 37 degrees Celsius without temperature correction. The natural increase in pH is accepted. Carbon dioxide is not intentionally added. The goal is to preserve intracellular charge balance, enzyme activity, and cerebral autoregulation. Biostat takes a different approach. Blood gas values are corrected to the patient's actual temperature. Additional carbon dioxide is introduced into the oxygenator gas flow. This maintains a temperature corrected pH of 7.4 and a temperature corrected carbon dioxide of approximately 40 millimeter of mercury. The result is increased cerebral blood flow and more uniform cooling. However, intracellular conditions become relatively more acidic compared with alpha stat. Now we come to one of the most important consequences of hypothermia. The oxyhemoglobin dissociation curve shifts to the left. As temperature falls, hemoglobin affinity for oxygen increases. For any given oxygen tension, hemoglobin holds oxygen more tightly. At first glance, the sounds beneficial. Oxygen loading in the lungs improve, but there is a trade-off. When blood reaches the tissue, hemoglobin becomes less willing to release oxygen. Despite excellent oxygen saturation, tissue oxygen unloading may be reduced. This is the classic left shift associated with hypothermia. AlphaStat accepts this left shift. The philosophy is that metabolic demand is also greatly reduced during hypothermia because tissue require less oxygen. The reduced oxygen unloading is generally tolerated. The focus remains on preserving normal intracellular enzyme function and cerebral autoregulation. pH takes a different approach. By adding carbon dioxide, a relative acidosis is created. This shifts the oxygen dissociation curve back toward the right. Hemoglobin releases oxygen more readily to the tissues. At the same time, carbon dioxide causes cerebral vasodilatation, increasing cerebral blood flow and improving cooling homogeneity. This is one reason PS-stat remain popular during pediatric cardiac surgery and deep hypothermic circulatory arrest. Let's bring everything together. As temperature falls, the neutrality point of water rises, blood pH rises along with it. Carbon dioxide becomes more soluble, causing partial pressure of carbon dioxide to fall. The oxyhemoglobin dissociation curve shifts to the left. Alpha stat accepts these natural changes. It preserves intracellular charge balance, enzyme function, and cerebral autoregulation. pH stat actively corrects blood gases by adding carbon dioxide. This increases cerebral blood flow and promotes oxygen unloading through a relative right shift of oxygen dissociation curve. Hypothermia is one of the most powerful protective tools available during cardiopulmonary bypass, but cooling changes acid base balance, carbon dioxide behavior, and oxygen transport. Alpha stat works with physiology and preserves intracellular homogeneity. PS-STAT modifies physiology to increase cerebral blood flow and oxygen unloading. Neither strategy is universally correct. Each has advantages depending on the patient and clinical situation. Understanding the science behind both approaches allows us to make better decisions in the operating room. Thank you for watching Circulatory Secrets. If you enjoyed this video, subscribe for more perfusion and cardiophysiology content.